everybody. Welcome to the International Mental Health Virtual Conference on the topic Building Up Nation Resilience, hosted by Department of Mental Health, Ministry of Public Health, Thailand, and the United Kingdom Government. Before we begin the virtual conference, may I inform the participant rule as on the screen. Please mute microphones all the time and set mobile phone on silent. And if you have any questions, please message inbox. On-site participation, please be silent during the conference. Now this is the time for conference. Please, Dr. Sankamon Karnum.
Dear Deputy Director, General of Department of Mental Health Thailand, Dr. Samai Sirithong Thawan, and good afternoon, distinguished guests and all participants. I am Dr. Sankamon Gornum, work as Head of Office of International Affairs, Department of Mental Health Thailand. I am very pleased that you have honor to be the chairman at the International Mental Health Thailand virtual conference on the topic of building up nations' resilience today. The Department of Mental Health, together with the United Kingdom Embassy in Thailand and the Purposefulity Funds Thailand, are organizing an academic seminar on mental health with the COVID-19 pandemic situation. The objectives of this seminar are conducting academic collaboration and being able to develop research on the topic of building up nations' resilience, including for the joint memorandum of understanding between the United Kingdom and Department of Mental Health Thailand. This conference, we have the honor of having expert speakers in building up nations' resilience from the United Kingdom, Singapore, and Thailand. There are about 300 participants, including Thai and foreigners partners, who work in mental health area from both inside and outside the Department of Mental Health Thailand. May I take this opportunity to invite our chairman, Dr. Smai Sirithong Thawan, Deputy Director, General of Mental Health of Thailand, to officially open the International Mental Health Virtual Conference. Dr. Smai, please.
Distinguished guests, ladies and gentlemen, on behalf of the Department of Mental Health, which has a mission to become a center for mental health learning and training center in ASEAN country and international level. As always, we improve and adjust our work to proactively respond to the challenge into the new government management system or new normal in many forms in order to respond to the behavior of individual of Thai society and international. In addition, we develop the mental health policy, public awareness, solving mental health problem, efficient management system, and good governance. The Department of Mental Health have operated on discussion and exchanges as well as disseminated academic work or an effective developmental work model with the foreign country, particularly the country cooperative networks of the Department of Mental Health, not only share and exchange knowledge, but also transfer it to the operator, suiting to that context. Furthermore, we can lead the well-being of Thai people and being a mental health leader together. The International Mental Health Virtual Conference on topic building up nation resilience will not be possible without cooperation from the United Kingdom Embassy in Thailand, the Prosperity Fund Thailand, the International Network of Department of Mental Health, the Institute of Mental Health Singapore. On this occasion, I would like to open the International Mental Health Virtual Conference on topic building up nations resilience. Thank you much.
Thank you very much for your special speech to open the International Mental Health Virtual Conference. On this occasion, I would like to introduce a little bit Dr. Thirsak Kong, Director of Bureau of Mental Health Academic Affairs, Department of Mental Health Thailand, as the moderator of Building Up Nation's Resilience section. Dr. Thirsak graduated medical doctor, Chulalongkorn University, certificate in psychiatry. His experiences are Doctor Office, Director, Office of International Affairs, Department of Mental Health from 2019 to 2020, Head of Psychiatric Division at Charan Kung Pacharak Hospital in 1995, and lecturer, curriculum builder, investigator in area of motivational interviewing project in MI for non-communicable disease. Dr. Thirsak, you have the floor.
Thank you, Dr. Sankamon, and our chair, Dr. Samai. Today we have special chance to talk about how we combat to the effect of COVID-19 pandemic. We all know that COVID-19 pandemic has brought effect to every country and every person for all area of life, including physical, mental, and economic, and also the well-being of people. And as time passed, we try to combat to the effect that all our country and nation have faced. So this is bring us the knowledge and the way that we practice that we know that can increase the well-being and also the resilience of the people in the nation. This is why that we in the cooperation activity with the UK government, the British Embassy and Prosperity Fund with the Department of Mental Health to manage conference under the theme the Building Up Nation Resilience. Today we have three speakers to share their knowledge and perspective on nation's resilience theme. The first one is Professor Sir Simon Wesley. He is psychological medicine and research professor of psychiatry at King's College, London, and a consultant liaison psychiatrist at King College and the Mosley Hospital, United Kingdom. He will present under the subtopic Why Pandemics Are Weak, COVID-19 and Mental Health in the United Kingdom. The second speaker is Dr. Joseph Leong Yunyi. He is the Deputy Director, Institute of Mental Health, Singapore. He will present Mental Health Resilience, the Singapore response to COVID-19 and beyond. The third speaker is Ms. Navini Krehong. She is Public Health Officer working at Division of Mental Health Promotion and Development, Department of Mental Health, Thailand. She will present Community Resilience, Fundamental of Mental Health Response to the COVID-19 outbreak. I think that under the topic of the resilience, we learn a lot from lesson in many countries. So it is the best time to learn experience of each country, especially the country that face with the effect of pandemic so much. I think that we would start with the video pre-record of Dr. Joseph Leong to present his slide and presentation. And then if any participant that has their question, you may place your question into the chat box. So our team will pick it up and manage to ask this question to the speaker that you have to one day answer your question. So I think that would be start with the lecture of Dr. Joseph Leong.
Hello, I'm Dr. Joseph Leong. I'm a psychiatrist by training. I've been in the field for the last 21 years. Currently, I'm a deputy director for the community mental health team at the Institute of Mental Health in Singapore. Thank you for inviting me for this talk. I'm also a board member of the Singapore Association for Mental Health, SAMH, and also board member for Caring for Life, which is actually a NGO, a mental health NGO that actually looks at public education for suicide ideation to prevent suicide ideation, reduce. And also an expert advisor for Caregiver Alliance, which is actually a mental health NGO helping caregivers do self-care so they can care for themselves and their loved ones better. So today we're going to talk about mental health resilience, the Singapore response to COVID-19 and beyond. And if you want to find out a bit more about my work also, I've done some work on the Singapore story in community mental health development and psychiatric rehabilitation and recovery, and the topic of social inclusion. This was published in the Asia Pacific Journal of Social Work and Development in 2019, the Singapore story. So today I'm going to share with you the Singapore story for resilience, the Singapore to respond to COVID-19. And we're going to look at the COVID-19 and the impact on mental health. We're going to look at number 3, the political and economic leadership that's so important to navigate crisis. And the third point is actually on stories of resilience, where we look at public, private, and also people sector. That is public, the government sector, the private sector businesses, and also the people sector, social sector coming together, and how we can actually help, and how sharing stories of resilience actually help people in the mental health arena. In fact, 1 year ago, Singapore praised for its initial coronavirus response, closes schools and offices to prevent second wave of infection. And this is our Prime Minister Lee Hsien Loong. Why Singapore wants a model for coronavirus response, lost control of outbreak. And this is the breakdown of the COVID-19 cases in Singapore. This infographics from the Ministry of Health, you can see, with imported cases, community cases, and DOM cases. And this is actually freely available on the government.sg websites, right? 569 cases, everything is counted, and even where the clusters are, and where all the various DOMs that are actually affected. So people in Singapore can actually access, open access to have information on where COVID-19 cases are. And this is actually a timeline of what happened. In January 2020, our first Singapore COVID case, 23rd of January. And then, of course, the travel restrictions started very soon. In February, there was the first cluster on the 4th of February, and 3 days later was LOSCON was raised to orange. That is our disease outbreak rating scale. And of course, tourist business was actually affected. By March 2020, additional measures were added to protect our seniors, safe distancing measures imposed, suspension of all activities at community clubs, residence committee, people association facility. There's also closure of public entertainment venues, and financial support for both low and middle income Singaporeans were actually given. Also, financial support for individuals and small, medium enterprises affected. By April 2020, we can see there was an outbreak in the old age home. And 2 days later, the circuit breaker, now known internationally as a lockdown, was actually implemented in Singapore to minimize the spread of COVID-19. And these were all the measures like working from home, HBL's home-based learning, closing down workplace and also school closures. And also at the same time, we launched a national care hotline where we learn a lot more about mental health. And of course, like many countries, there was a circuit breaker extension until the 2nd of June. And we implemented then new measures like safe entry and safe management practices so that we can reopen the economy by the end May, June 2020. And indeed, there is actually impact on mental health on the general population. There was significant psychiatric mobilities, such as anxiety, depression, panic attacks, somatic symptoms, PTSD, that's so common. Both tears and fears over COVID-19, more in Singapore seeking help for mental health. That was the Yahoo News last year in 27th of April 2020. Of course, economic losses, community closures, and also joblessness. Singapore headed for the worst recession since independence. And of course, more Singapore's being a food paradise, restaurant closures, hawker centers are all affected. 81% of the restaurants actually said they cannot survive beyond 6 months. And actually within 20 days of the launch of the National Care Hotline, actually we received 6,600 calls, right? And about 15% asking about temporary relief funds and also 11% on financial issues. And this was the budget. There was put up 54.8 billion in budget. The first budget was called a unity budget, where we want to unite Singapore in this COVID situation. The second budget was March 2020 was launched. It's called the resilience budget, right? It's a bigger budget, right? Drawing from past reserves. And finally, within there was third budget that was put up. It's called the solitary budget. And I still remember Prime Minister during one of the broadcast address, she said all the ministers will take 1 month pay cut to stand in solitary with and the civil servants, with the rest of Singaporeans. And these are the details of the payout. And of course, as a frontline worker in healthcare, we are really at the front line. And then many studies have already shown we need help and support among healthcare workers, such as SARS in 2003. Psychological impact of outbreaks on health care staff cannot be ignored. And of course, fear for self and others, right? In Singapore H1N1 pandemic response. Myself being a frontline worker, a doctor, I still remember in the early days of COVID-19, we are masked up, but when people come in and cough, we have to really scramble to isolate the person, and we actually need to clean down. And of course, I'm worried whether I'll be infected. But actually, more importantly, I'm concerned whether I'm asymptomatic carrier, and if I go home, will it affect my loved ones? And I think that's something that healthcare workers always struggle with. We have frequent updates, and we have COVID-19 updates from Singapore. This is actually an update from NUS, our medical school. Mental health strategies to combat COVID-19 beyond paranoia and panic, right? And from the National Care Hotline, we gather that a lot of people have actually gone online. There's so many webinars and information. There's COVID-19 one-stop mental health platform was launched to match users with resources and helplines. That was in July 2020. Are you feeling worried, anxious, or down? And how do you manage those emotions? And of course, we have the various categories like, when you're not feeling safe at home, where there's family violence, when you need financial help, or you need some work support, or you are a caregiver needing caregiver support, or if you have been active outside, how do you keep fit and healthy during the lockdown and circuit breaker? Of course, this is the Singapore Association for Mental Health, SMH. We also have a road to resilience, shaping an adaptive mindset with hope. A lot of people have gone online, this Healthy Mind Online. So there's another platform, feel heard, feel safe, and find solutions. And that's myself online. We also have peer support specialists. These are persons who have actually recovered from mental health issues, and the topic is on mental wellness. And in August, National Day 2020, COVID-19 Heroes, Mental Health Advocates Bridge Support Gaps online. I think it's so wonderful that Nicole Kay, who's a founder of Tapestry Project in Singapore, who launched a series of coping COVID-19 stories, actually was recognized. We also have a Facebook page, Total Wellness Village, and this is the Facebook page where Julius, who's actually a peer support specialist, who used to suffer from chronic schizophrenia, depression, and anxiety, actually came up with this page. How do we gather together towards an inclusive, total wellness, resilient global village? And we post events online on Facebook, mindfulness conference, enhancing resilience and performance, right? We have local speakers. Of course, we have faculty from Harvard Medical School, Harvard University, and all coming to join us online. Okay, this is actually a time for us to share a story of resilience. Let me switch to this YouTube. Okay, and this is a YouTube. You can see the Royal Singapore, and this is about Singaporeans. And you can see they have jobless during pandemic. Her kampong helps the lost and depressed. But let's take a look at the jobless during pandemic and what sort of lesson did actually Joel actually learn.
My age? What do you think? How old do you think I am? No, I'm more than that. We are more than that. I'm Joel. I have not really been working for the past almost half a year. I was actually in sales, retail industry for many years. I involved in a lot of different type of trade also. Email to phone, but it seems like we're not even we're not getting any response. Of course, I feel devastated. I feel sad because I know that during this period of time it might be very hard. But the most important thing is it because of my age? Am I really like too old for those positions that I apply for? Of course, frankly speaking, I feel very sad. Like I sent so many resumes online, I didn't even get any response. So I was thinking like maybe they doesn't want to take me in as a pro. This is one of the things that actually worry me most. Yeah.
WSG is Workforce Singapore.
It was just like a normal like going down for job seeking or job hunting. But then I was actually very surprised because my first time I went down there, I met this lady from Korea. I was very surprised that the way she talked to me is not just like trying to help me getting a job. She was telling me a lot of things about age actually doesn't really matter on a lot of jobs. It's the kind of attitude the kind of mindset you have.
Attitude and mindset change. Wow.
Work.
Towards
So
work.
it helped me to actually rectify some of the things, helped me a lot. And then this argument throughout for so many months, say interview, nothing. And then this is the first time whereby somebody talked to me about what I should look for in a job and how should I go for it. That's why now at least I feel better, more confident. So at least that leaves them a better impression.
Keep at it, find confidence, resilience, bouncing back.
After like Korea's spoken to me and then all the so at least I managed to change the way my mindset from how I like to go for interview. And also like from her help I able to go for some other job application. And then there was this roadshow whereby she recommended me. It was this Venus Beauty. It was very weird experience because like it's the first time I went down there. It was like I was inside the booth, like speaking just to the laptop. So it was very funny because you can't, even though it's like a face-to-face but from camp, kind of weird feelings that I have. But at least from what I South Korea taught me, I'm able to communicate with them well and even impress them with the interview. So the interview was going on very. So that is something new to me. So I'm not sure whether I'll be able to get a job. So I'm a bit nervous right now because I got a call to come out for interview. The hope is there. I really hope I can get a job. And from what I know, it's the boss is really very friendly. So I hope everything goes well. So my age, I'm 30 plus. I'm almost 48 already. Quite alright. Okay, throughout this the whole journey from even before I get to know all these Korean content and everything, I always have this mindset, age is a hinder to a job. But after I been go through all these step by step and then until where I am now, I realized that even though my age is 47, there are still so many things for me to learn. Throughout, I realized age is actually just a figure. No matter where you work, how you start, you need to have a correct mindset, the
Positive mindset, yes.
All these Italian restaurants,
resilience, bouncing back.
So I'm happy with what I did do. And glad that I'm here.
So we wish Joel all his best in his new work application, and really support is there. His struggle is real, right? There's a lot of people who lost their jobs. The struggle is real. Mental health is affected, but the support is also there. Okay. Let me switch back to the presentation. Yes, in fact, this is one. It is the resilience budget, and you could see actually the self-employed actually do get income relief scheme, and you saw job seekers like Joel himself. Actually, WSG launched a virtual career fair. That's when we actually talking through the laptop. I want to say it's just like this webinar here, a virtual conference. And even for families, we have care and support, and with additional help for families with young, and even groceries. And even now, we still a lot of debate about the budget on economic and psychological resilience are key to emerging stronger, and that's so important. Our Prime Minister was saying we need to reshape the economy, and also we need to train our people, Singaporeans, to have a different mindset, a positive mindset to face the future together, emerging stronger together. And Parliament debate on a new mental health wellness curriculum in the polys to be rolled in the ITE, which are Institute Technical Education. And here you see wellness mental wellness curriculum launched at polytechnics and ITE colleges, and that is just very recent, 2 weeks back. And here, more help needed during COVID-19 pandemic, said mental health expert. And guess what? And this is just yesterday, March 16, 2021. And let's hear again for another story of resilience, which is, I think, so important. We want to share stories of resilience, people struggling, and then actually getting support or even overcoming the challenges. Just share this.
Helping during what COVID, helping, don't know what, again helping. Cannot understand, I'm not helping. Okay, I'm here to seek their permission to help me instead.
Ooh,
wow. I hate this word helping, cannot understand.
The unhelpful charity worker.
Hi, good morning. I'm Fion. This year I'm 50 years old. In the daytime, my job, I'm a broker. Broker, I do buy and sell club membership, not my club, but any other clubs. In the night, my passion is that I like to search for homeless. But on Sunday morning, it is my hobby. For the past, since at the age of 16, every Sunday morning, I like to go door to door knock to search for needies, and I like to capo what is their needs, so that I can measure my ability and do really what I can for them.
Busybody, capo.
So I came from a very low income, I would say. My father had to work the whole entire day in a Van Houten chocolate factory, and my mom has to work night shift. So that one parent in the day around and another parent at night around for us, three of us. So at a very young age of 7, I started working. At the age of 8 and 9, I started distribute newspaper. When you go and give newspaper, you see landed property with dogs. You saw that they got fresh milk. You look at the brand, you capo around, you check who is the owner. Go to interview and tell the owner, hey, I can give newspaper, I can at the same time also deliver milk. So that's why I have many form of job in the young days, like 7 years old, 8 years old. Of course, you ask me, you don't need to sleep. How do you study? Last time school days and now different. Now after school, you got tuitions, you got CCA, you got everything. My time, halama. Come out from the school, need the bag, you don't throw away already. No need to study what? Come back is shower, eat, start to play. So at a young age, I'm already upbringing in this manner that I have no fear. Every year I look at my report book, cheerful, friendly. Now I translate as capo lah. Never stop asking.
Capo is a busybody, a very curious attitude. It's really what's happening on the ground. Yeah.
Downstairs, the queue is getting longer and longer and longer and longer. Everyone is over here. Tell them to also disturb 1 meter. 如果你要快for last block, 你就 concentrate on last block. 如果你要 first block 来，你want to concentrate 一班一起做. Nobody have ever stopped me from cleaning the house. I proudly even speak to Goh Chok Tong. When Goh Chok Tong asked me if you want
Goh Chok Tong was
speak to our orders,
senior minister, previous prime minister.
Yes, you see Marine Parade, Block 53, I got one auntie holders 80 over years old. How many times we try also cannot? Line up your team, your WeCare, whatever, then line up. Video, one attempt, 3 conversation only. Auntie, 有人在家吗？没有人在家 ，OK， 外面的东西不是你的啊 ，OK， 我清掉。有人在家 ，OK， open cleaning start. Because we know what we are doing, and we know very well that we came with a heart that we are so willing to beg for you to accept what we are doing. So we have no issue. Because we did not came with a heart like wanting to pin you down that you are needy, you are beggar, you cannot be a chooser, We want to do this, you should be thankful. We never come in this kind of heart. We come in a heart of very thankful seeing an elderly ama. We treat you like our grandmother. We want to trim her hair, we want to trim her nail, we want to trim her toe. We want to bring you go and eat, Yeah, so we came with this kind of heart. Oh, yeah, Yeah, you remember me, Yeah, that time my daughter come here and do the massage for you. Yeah. How come you know me? Because of this, right? Yeah, I know. warm, even the blind can feel it. Even the dumb and deaf can feel it. How you warm people's heart? That's very important. That's why I always tell all my volunteers who came to us, one thing, only one request. You no need to donate money. We reject all money. But you cannot donate your tears. You cannot come here and cry. The needies have more tears than you. Come here, come with respect. Okay, do whatever with no expectation and accept all outcome.
Going door to door and knock.
Keeping Hope Alive, why are we different?
Because we are not an organization, we are a platform for people to come to. It's such an opportunity.
We assess all the so Keeping Hope Alive, we believe when we exercise what we are doing on Sunday morning, we make very sure that we must understand their needs before we apply what we can. And then when we go, we don't just give toothpaste, toothbrush, canned food, Maggie mee. Okay, some ama apong don't even have the teeth to brush. What's the toothpaste and toothbrush for? Yeah. So this makes us very, very unique in Singapore. We do not understand their needs before we apply our ability. This is keeping hope alive. And we never go with broken English. I know what it's called keep hope alive because we keep doing this, so we call ourselves keeping hope alive. This I'm very proud and very happy. 对不对？ Good. Okay, 可以出去了。他只是 allowed 这个而已。
Okay, so indeed we want to continue to be keeping hope alive, and I think that is part of the resilience story in Singapore. Indeed, COVID-19 has actually impacted countries all over the world, and mental health is something that is actually called a hidden wave sometimes, a third wave, fourth wave, and leadership is so important to actually navigate any crisis. And we are very fortunate in Singapore for our very strong political leadership and all the plans and government policies that have been in place in the public sector. Of course, we also have the private sector, the employers who continue to create jobs for Singaporeans. And finally, the people sector, which is actually the social sector where we actually see all these stories of resilience, stories that we hope that we continue to bring Singapore into the future. And with that, I thank you.
Thank you so much, Dr. Joseph. What you show us, I think that we all accept that we understand more. And I think that the experience that we have together, what we have done in the policy level, into the service system and also to the people level. Very fascinating story, especially for the wording, keeping hope alive, and the story that changed the flow of the victim into the resources. I think that what you present make us more experienced and more understand about lesson learned in your country. It is time to move to another lecture, the experience in United Kingdom. We have Professor Sir Simon Wesley, who will present why pandemic are with COVID-19 and mental health in the United Kingdom. Professor Sir Simon, please.
Good morning, colleagues. At least it's good morning in England. Very early in the morning here. And it's a pleasure to meet everybody and say hello to my international colleagues. Now, I feel a little out of place at this table because, as I'm sure you know, the story of COVID, coronavirus, etc., in the United Kingdom has not been remotely a happy one. In Thailand, I know you've had 30 deaths from corona. I think it's 80 in Singapore. We have just passed 135,000. We have had 4 million cases. Our hospital systems has on 2 occasions come very close to collapse, latest only 2 or 3 months ago. We still are at the moment in extremely tight restrictions. And although our vaccine program is one of our few successes, of which we have something to be proud of, the rest of the story here in the UK is something that is going to dominate politics and recrimination and blame for years to come. So it is not a story of success as you have in your countries, and deciding what are the reasons for our failures will occupy us for years and years. Now, 2 things to say about me. First of all is I belong and I founded a society for the abolition of PowerPoint. So I decided some time ago to stop using PowerPoint when talking to audiences or medical students or media, etc. So realizing that English is not your first language for many of you, I will slow down, but I just simply don't use PowerPoint. I much prefer to just simply talk and make it up as I go along. So that may mean that if I drift off topic, so be it. Now, I'm a psychiatrist, and you all know what psychiatry is, and I'm also an epidemiologist. So my training was in epidemiology, and one of the few advantages of the COVID crisis has been, for the first time in over 30 years of academic research, I no longer have to explain to most people what epidemiology actually is. Now half our population know, and the other half of the population think they are epidemiologists, although most of them aren't. And I spent a large part of my career researching why, how people react to adversity, but often from a population epidemiological perspective. I'm also the psychiatrist for the British Army and have done, again, around 30 years of work on how occupations such as soldiers, but also police, medical staff, all sorts of different groups deal with threats and adversity. And I direct a unit funded by our public health system for this purpose. And you will imagine for the last 12 months, very few of us have had much sleep. And I used to be on a scientific panel on emergencies, which used to be top secret. We weren't even allowed to say we exist. Now everybody knows who we are. I'm not on it anymore, thank God. And nothing is secret anymore. So this has been an extraordinary threat to our society, and one in which we are still struggling. Now, at the start of this pandemic, myself and colleagues wrote a paper in The Lancet. This is still less than a year ago. It's been out, I think, 10 months, predicting what the results on the population would be as we entered. We wrote it just as we were getting the first few cases, and by the time it was published, I think we were indeed already in lockdown. And this clearly has become an extraordinarily important issue around the world. And this paper, which is, just a standard systematic review, to be honest, has already been cited 5,000 times in the literature since then. I don't think that's a credit to the brilliance of our work, but it is just a marker of just how extraordinary has been the reaction to the pandemic around the world. And what we said was something that will seem so obvious to everybody, you wondered why we even bothered, but at least we were the first, which was that quarantine and lockdown would have psychological effects on the population. These would not be small. They would affect everybody, but certain groups would be more vulnerable, in particular those with pre-existing mental disorders. That the biggest determinant of the impact would be economic, those who are unable to maintain their livelihood, and the greater the degree of coercion that would be used in a population to enforce these measures, the greater would be their long-term psychological impact. And sadly, all of those have proven true. Now, in the UK, we can therefore say with some confidence now that the mental health of the population has declined during the crisis. But we must remember that mental health in the United Kingdom and in many, many other countries as well was not fantastic before all this happened. We were already highlighting a strange increase in anxiety and depression in one group of our population, which was young people aged 16 to 24. This was in the year before the pandemic struck and had been a trend for the last 5 or 6 years. We can argue all day for what this was due to, but the point I'm making is that because I'm the leader of our profession in the UK, I do an awful lot of media, and I spent most of my time talking about the mental health crisis in the UK before the pandemic struck. And what it has done is what these things traditionally do, which it has not created something completely new, but it has exaggerated a trend that was there already. And when we do population studies, it's our job, we showed that even taking account of the existing trend going upwards, it had got faster and larger, clearly as a direct result of the pandemic. So before we started, the data was that the easiest way of thinking about it is that 1 in 10 of the adult population were suffering or had some form of depression or anxiety. Now this was 1 in 5, big change. 1 in 9 of our children had mental health difficulties. It was now 1 in 6. And those rates have fluctuated as the lockdown progressed. There was a small drop in many studies, and then back up again as we had to repeat the measures as we entered the winter. So we are still in trouble and struggling on the mental health side. Now, of course, that is not surprising for the reasons I've just said. We have a great threat. We have lost 135,000 people in extremely unpleasant circumstances. We probably have a large number of people who have been unable to grieve or come to terms with their bereavement because of lockdown and our hygiene measures, enforced hygiene measures. Very few have been with their loved ones when they die, and it has been a thoroughly horrible and unpleasant experience. But we can say a little more than that, because as I say, I've been interested in how populations react to adversity most of my career, and looking both forward in big prospective studies in the military, but also looking back to see how people managed this before. And the answer is that most people deal with adversity pretty well without the help of people like me for most of the time. And that's been true for as long as we've been able to study it, going back to the Second World War, and indeed even earlier than that. It is also true that people like me, and also politicians and policymakers, psychologists, psychiatrists, all sorts of people have, throughout my life and before that, underestimated what we used to call the morale, but now we call the resilience of ordinary people. And we have a history of putting in, well, first of all, not predicting this fact, but also putting in interventions, many of which have been useless and some have done harm. So the tradition of psychological debriefing, which I don't know if that caught on in Thailand or Singapore, but it certainly did in Australia and New Zealand and some other Pacific Rim nations, and it certainly did in Great Britain and America, which was that when anything bad happened, we would send in trained counselors within hours to the scene in order to ask people, what was it like for you? You saw someone killed, a bomb went off, a fire, a terrible disaster. You were involved. How was it for you? What did you feel like? And then to say, what are the things that might happen to you? These are the symptoms you might develop. Here's a number to call if you do. When we were finally able to examine this by means of randomized controlled trials, which are my passion, I've written a book on it actually, Not that you would know, I don't think we sold very many copies, but nevertheless, I've written a book on randomized trials in psychiatry. But when we were able to do those trials around the world, we found not only did this not work, it actually made people worse. So too much early intervention from mental health professionals was actually reducing the resilience of people who had been exposed to adversity. And we were able to suggest why this might be, partly because we were just, we have defense mechanisms for a reason. It's not the best time to relive in your imagination that you've just seen somebody you know blown to bits by a terrorist bomb. That time will be later, not now. It is a one-off intervention, not the kind of treatment that I will give to soldiers with PTSD, post-traumatic stress disorder. I won't just see them once, I may see them 12, 20 times, slowly, giving them tools to deal with the anxiety as when I asked them to confront whatever it was that was responsible for their mental ill health. And finally, it also professionalizes, medicalizes what is a normal emotion. To feel fear in these circumstances, that is normal. It does not need help from people like me, far from it. What does it need? Well, what do people do? We have done study after study, and unfortunately, in the history of our population, there have been plenty of examples for this to happen. Of the London bombs in 2005, of the Litvinenko affair, when Russian spies were around London depositing polonium-210 in all sorts of places, of the Salisbury poisonings, of the floods that we had that were so devastating some years ago. And we're pretty confident now we know what people do. They do what you and I would do. In times of adversity, the first thing they call upon are their social networks. The first thing they do these days is pick up their mobile and call their loved ones to say, I'm okay. And we showed in the days after the London bombs of 2005, we showed that if people could not do that, and many couldn't, they became more anxious and fearful. Now you may say, quite correctly, you get paid to do this kind of research? Come on, that's so obvious. And it is obvious. It's what 98% of the population of London did. Hardly any of them sought professional help, but they wanted to talk to their loved ones. But when we followed these people up, we found not only were they more anxious on the day, but they were still more anxious 6 months later. And that made an impact. And now in all our disaster planning, our civil defense work, all of that work, which I know goes on in all your countries, we always say the most important thing when there is a crisis, that is to provide people with a phone charger. And when we brought people back from Hunan at the start of the crisis, I was very pleased to see that when they arrived in Heathrow, before we did all the other things we were going to do, everyone, there was a big bag of phone chargers so people could immediately contact their family and say they're okay. And that's now become part of our disaster prevention strategies on the psychological side. But then we get to the fundamental wickedness, the word I used, of the pandemic. The pandemic, throughout history, of course, mankind has been exposed to all sorts of disasters, and I speak as someone who has studied the impact of war for many years. But there are many others as well, natural, man-made, all sorts of things. But pandemics have a unique property that nothing else has. It creates the adversity, the fear. 135,000 people have died already in this country, and unfortunately there are still more to come. But at the same time, our efforts to contain it impede, and actually sometimes, as at the moment, almost entirely destroy the way in which normal people deal with that adversity, which is by talking, contacting people, meeting people who they know, who they knew before, who they knew during, and who they will know afterwards. In other words, their family, their friends, their colleagues, not necessarily in that order, but in some form of order. They may perhaps talk to their own family doctor, we are justly proud in the UK of our primary care system. Not much we do in the healthcare system, which we think we are international leaders at. Probably palliative care and primary care are the two. But yeah, they will know their GP, their general practitioner. They may talk to them, or they may talk to their religious advisor. Less so perhaps these days, or no, not in some communities. But they will talk to people who they knew, know, and will continue to know. And as I've just said, quite correctly, they don't want to talk to someone like me, and that is right and proper. But the pandemic has changed all that. And the biggest reason why we see this general increase in psychological distress in the population is because the pandemic, or more specifically, our efforts to contain it, have prevented all of that. We have, once again, for the last 4 months, all of us been in lockdown. We have not need to be coerced to do this. Indeed, the degree of popular compliance has been extraordinary. We follow as you do. I don't think we do it as closely as you do, actually, but we follow, I'm talking now to my colleagues in Singapore, but we do know from mobile phone usage, things like that, what is the degree. We don't know who's doing it, but we do know overall what the patterns of population movement are, and maybe 90 to 95% of people complied, or most of the time, with the first lockdown, and indeed, it's not that dissimilar with the second. Indeed, the degree of compliance is actually higher in many respects than the government require, and the reluctance to end the lockdown is actually seen still in the majority of the population. Many are not reluctant, but others are more reluctant because of the state of fear that the pandemic has done. Now, we make many analogies with previous tragedies in our nation's history, just as you do. We, of course, have different tragedies. Occasionally, the British have been involved in tragedies all around the world. That's a product of our complicated history. But the one that we fall back on most, as we tell each other stories, and our politicians tell us stories, and indeed our monarch tells us stories, is the Second World War. And it is normal for our current Prime Minister, and indeed all our Prime Ministers, and indeed for our Queen, when she addresses the nation, to reflect back and use analogies drawn from 1939 to 1945, the most tumultuous period in our, well, other than the First World War, in our nation's recent history. But that is not a good analogy, as I sometimes bore people by saying. Why not? Because during the Second World War, we did not have social distancing at all. Indeed, we had the opposite. Our government, as a matter of policy, from the start of the war to the end, did not close its restaurants, pubs, bars, clubs, cinemas. Indeed, in 1940, the worst year of the war for our civilian population, 1.5 billion visits were made to cinemas. 1.5 billion. During the COVID crisis, it has been naught. None. So 1.5 billion visits were made at a cost of lives. Many lives were lost in direct hits on cinemas, bars, clubs. 30 children were killed when a bomb hit a children's matinee performance in Brighton. It was covered up. Population were not told, but nevertheless it happened. And they did that because they knew how important it was for people to continue to have social interactions. In those days, they said, to maintain the morale of the population. Now we don't talk about morale, but we do talk about resilience. That's the modern word for morale, but they knew exactly what we were talking about, and they also knew how to protect it. Now, regrettably, those options are not open to us, but it is also worth reminding what the other options were. For example, the second thing they knew was in the immediate aftermath of tragedy was to protect physical health. That was the first thing. And we see that now as we look at our population of healthcare workers and the studies from Singapore and from China that I have seen. reflect this very clearly. Our healthcare workers, the first thing they want is not psychological support, but proper equipment. And until we sorted out our protective equipment, PPE we call it, their mental health was poor. But it improved when they had confidence in their PPE. So that's the next thing that we do to maintain resilience, is to give people the protection they need. The next thing we do is to ensure that they do not get exhausted. And this came out of Wuhan very fast. And we have done our best, not entirely successfully, but nevertheless, we've done our best to ensure the next way of protecting the health of people exposed to the virus, mainly in our 1.4 million healthcare workers, but not just, is to ensure adequate rest and so on. So these are the two most important things that we must do to protect population mental health. And then, of course, I've already heard the last speaker say this, so I won't repeat this. Our government, despite some of its failings, was very fast, because it was part of our planning, in which I had taken part, to ensure that jobs would be protected. And I think all around the world, that lesson has gone home very hard indeed. If people are going to lose their livelihoods, they will not respect quarantine, full stop. And we have done well at a cost that is astronomical, but nevertheless, we did well immediately as we entered lockdown to announce a huge financial job security package. So that's the third most important thing to protect resilience. But then we finally do come down, well, what else can we do? Now, I heard from the previous video, uplifting stories of people volunteering. But again, it's very difficult to do that in a pandemic, actually. At the moment, it's close to impossible. But again, that kind of community-based action is very important, but very hard to do. Again, why pandemics are essentially wicked. So yes, we do all the things that have been mentioned. We have helplines. We have, in my hospital alone, we have 70 different staff support systems. We rarely know if any of them are working. We can't tell. They're not. We're doing a trial now, but I think probably most are all right, but I doubt that very few are doing very much. And I would repeat that across the population. There's been a big investment in mental health support of the direct kind. I suspect for most people in the UK, it passes them by. And if it does help, probably not much. But what we do know from our work now over 30 years is that the first thing, as I've said, is to encourage people, even in the poor way that we can, but nevertheless, is to, and it's interesting how the previous concerns that we had about social media affecting the mental health of our young people have now been replaced by an appreciation of how important it has been, as much as it can be, in helping people's well-being. And the demonization of social media has been replaced by an appreciation of its strengths. We have stopped blaming the medium for the message, I think. But that is not, of course, enough, and it never will be. So probably then, the last thing I'm going to say is the other strand that we have been promoting over the last 30 years, beginning with our work with our armed forces, getting rid of the psychological debriefing and those trained counselors, and instead ensuring that you get psychological support from, I mentioned, family, friends, colleagues. But if that fails, the next most important thing in your life is always the person you work for, the next person up that you report to, easy in military terms, but everybody reports to someone in the entire working environment, someone. And we have shown, I think pretty conclusively, and our colleagues in Australia have done some wonderful trials of this, that if your boss, i.e. the next person up, is reasonably empathic, takes a reasonable interest in you, ensures that you are safe, protects your physical environment, and shows just a fairly normal common or garden decency, and has just the simplest of mental health skills that can be taught in a couple of hours. We're not talking about the 6 years or longer than that, 12 years it takes to train a psychologist or a psychiatrist. We're talking about the morning it takes to train a Royal Marine sergeant in simple skills. That is probably the most important thing we can do, other than, finally, of course, end the pandemic and end the restrictions to protect a nation's resilience, or indeed, as we would have said 70 years ago, the nation's morale. Thank you very much.
Thank you so much, Professor Sir Simon. I think that the experience that you share with us make a little bit different from what we learn, especially in Thailand and in Singapore. And there are some special issue that you raise. I noticed that for in general population, some intervention that we have to do to control pandemic may affect to mental health, especially for to control the socialization of the people. And this way of strengthness of people in the past, the social connectedness is the very strength of human have changed into another way to combat to this time of trouble like this. And I think that there are some questions about what is the lifetime and life intervention that we should do to increase the mental health in the people, because if we do it not at the right time or the right intervention, this may bring mental health worsen that maybe there are so many experiences like this. And also, if the participant has a question, you may put it into the chat box, so our team will select it and prepare to ask our speaker that related issue to answer your question. Okay, let me move to the third speaker. The third speaker will show the picture in Thailand, the way that Thailand faced with this pandemic and to combat the mental health effect in Thailand. Ms. Navini Krehong will present community resilient fundamental of mental health response to the COVID-19 outbreak. Ms. Navini, please.
Thank you, Dr. Thirsak. Good afternoon, Thailand and other Southeast Asia country, and good morning, UK. I'm Navini Krong. I'm working for Divisions of Mental Health Promotion and Development, Department of Mental Health, Thailand. It's wonderful to be here today and really happy to be sharing with you some of the work we have been doing responding to the crisis of the pandemic and how we have been promoting mental health and well-being in particular. Can I have my slide, please? Next slide, please. What I am going to talk with you today is trying to unpack 4 key points here. First, I think it's important to highlight a bit how mental health response are important for people's well-being. At the second, I am going to talk about a comprehensive mental health action plan responding to COVID-19 in Thailand. But today we are going to focus on a community mental health action called Community Mental Health Vaccine, which mainly use the theory of resilience to promote mental health. And the third part, I will show you what we have learned along the way, what's happened in the community after implementing this national policy. Just want to highlight the benefits of community resilience on disease control and mental health promotion. And closing with some of policy recommendations on what we can do together to take care of people mental health during this crisis in short term and long term based on community approaches. Next slide, please. So just taking a step backwards, even before the pandemic, mental health is one of the most neglected area of health. When I say the most neglected area of health, it is not just about low investment in mental health, but also lack of awareness of mental health among public and local health professionals and local policymakers. At this time, people only focus on disease control and addressing economic issue, which means rising awareness of mental health this time is much more harder than before, I think. But with the idea of no health without mental health, we have been trying, never stop promoting policy, mental health policy action during this crisis and are going to beyond. Next slide, please. This is a study about social impact of COVID-19 in Thailand last year. When we look at this busy framework, I think it's just a good opportunity to raise mental health awareness along with social outcomes. In this slide, there is no arrow directed to the impact of COVID-19 on mental health, but the fact is the COVID-19 pandemic has affected everyone in some way. There have been many negative impacts, including illness and loss of life, psychosocial isolation, loss of schooling, employment, and financial hardship. All of these events have significant psychological effects on individuals, families, and communities. Moreover, as you see in this framework, the social outcome that affects by COVID-19 outbreak, such as poverty, social protection, education, and violence, all of these have link with mental health problems. And these impacts are not, however, evenly shared within society. They have particularly effects, for example, people on low income. And today I would like to emphasize the link between mental health problems and poverty. Next slide, please. We don't talk about poverty that much because we as a health professional or mental health professional might think it's not our job to address this kind of issues. However, the link between poverty and mental health is so strong. And Thailand is an upper middle income country with a population of 64 millions. We cannot deny that many people in our country are suffering from poverty and adversity. The COVID-19 crisis has turned into a global economic crisis, putting at risk of health, jobs, and income of millions of people around the world. In Thailand, there are more than 500,000 people unemployment in last December, and 2.5 million are furloughed workers. The study has shown the link between poverty and mental disorder, and poverty can be both cause and consequences of mental disorders. As you see in the summary, poverty has a strong association with mental health, with mental disorder such as anxiety, depression, and poverty increase severity of mental disorder. Living in poverty contribute to longer course of episode and worse outcome, and mental disorder associated with lifelong disadvantage such as low education, poor housing, indebtedness, inability to make payments. When we put everything together, it is an undeniable fact that promoting mental health and providing mental health care during this crisis and this kind of public health emergency, along with poverty alleviation intervention, is required. It's not an option. Next slide, please. Next slide, please. Now we are moving to talk about mental health response in Thailand and about mental health promotion in particular. Next slide, please. We have a comprehensive policy action plan called the Combat Fourth Wave of COVID-19 Plan. The plan contains 10 actions in 6 strategies, and this plan outlines 4 key areas of intervention during the pandemic to help and support the population as a whole, including promotion, surveillance, treatment, and recovery. The last slide. Yes. Today, I am going to focus on promotion and resilience, which is the key areas of intervention that we use at individual, family, and community. Next, please. But the main idea of today is we are going to focus on community mental health vaccine policy actions that aim to promote community resilience to create a positive effect on mental health and well-being of people who are in a resilient community. Next, please. The science behind mental health vaccine is resilience, and resilience refers to the capacity of individual or family or community to cope with stress, overcome adversity, or adapt positively to change. And this slide shows evidence-informed factors that promote psychological resilience used to design our program. When we are talking about operational factor in each level like this, we can imply to bio-ecological model of Bronfenbrenner, which is based on the idea that the relationship person have with the parents or families impacts their health and well-being, and that these relationships are affected by the work, school, and community setting, which are in turn affected by broader social, cultural, and policy conditions. And these many layers of relationship and environment interact with each other, influence how people develop and become resilient. Next, please. There are a number of different approaches to resilience. At individual level, actually, we have been promoting mental health in workplace for years, and positive psychology were often used to design and develop our interventions, and mostly as a group training and also self-learning program. The popular theoretical basic is resilience, so we use resilience for years to promote mental health in workplace, and this time is, I think, it's a good opportunity to raise awareness and promote our existing intervention among workers who are at risk of mental health and behavioral problems. At family level, we use mass media and as a channel to promote resilience, to promote the message that we want people to know to cope with their mental health, such as social media and TV program, which can reach many people across the country. And the last one is what we are going to discuss today. We created a community engagement toolkit and guideline to promote community resilience, and at the same time integrate mental health care into community practices. Next, please. How can a community be resilient to COVID-19? This is the question that we use to create a community-based action guideline, not only mental health, but includes other aspects of health, physical health, and social into the guideline regarding to human basic needs. Next, please. This is my classic drawing, actually. I should use the real graph to explain epidemiological characteristic of COVID-19 outbreak in Thailand, but I just want to show my skill on drawing. By the way, Thailand have been during the second wave of COVID-19 outbreak that had been raging since December, and now it's likely to slow down. For the first wave, we had to use evidence-based practice from literatures and our experience of crisis management to create policy actions and guidelines with no time for testing for in real-world setting. and we need fast-track implementations of evidence-based practice. So the first wave in last year gave us an opportunity to learn, and we learned a lot by doing and to reflect what we have learned and improve our plan and interventions. And then when the second wave happened, we have been ready to respond to with knowledge, resources, and a strategies aiming to help and cover more people. Next, please. Next, please. And this slide presents the techniques and practice that we apply to develop a general guideline for community leaders to promote resilience in their community and mental health and well-being as well. Next, please. We use metaphor vaccine and short words to explain the concept of community mental health vaccine policy actions. And this supposed to be self-explained words about goals and action that people can use to promote community resilience in their community. In Thai words, it is easy to remember and understand. And I hope this gonna make sense to you when it was translated into English. For enhancement and to use, which means we use community efficacy and community network to enhance or promote sense of safety, calm, hope, and destigmatization in the community. Next, please. Low cost recommend activities based on community network and relationship and community efficacy were guided to leaders and primary healthcare staff in the community to support people mental health and psychosocial needs at the community level regard to key human basic needs in crisis, safe, calm, hopeful, and destigmatization. And I will unpack each of the four enhancement further in the next few slides. Next, please. Like I said, community efficacy and community network are two main community resilience components which play an important role of mental health response in the community. Next, please. Because the mental health consequences are expected to be present for longer than the COVID-19 pandemic itself, now is also the time for mental health practice delivery to transform towards the ethic of nothing about us, without us, with meaningful participation by people in strengthening the mental health practice in the community. Even we have the whole package of practice, it is might not going to be success and last long without participation process that allow them to adopt their own culture and contact, which can enhance community trust and empowerment. We need to find a new creative ways of listening, being with, alongside, and part of community to learn about their strength and to work with and through other that strengthen this. We use this 5 step, a simple 5 step, to make change and enhance resilience in the community. At the same time, is to integrate mental health promotion into their practice. The first, promote a knowledgeable community. It is a step of preparations. So we have to make sure that people in the community are informed and know how to respond to the crisis and know how psychological support and mental health response are important. The next, identify community problems and estimate needs. We need to support them to better understand the constants they are in and how to make the use of possibility for responding to COVID-19 in all aspects: physical health, mental health, and social. The next, review community efficacy. We need to seek the value and amplify of strength, resource, and knowledge already present in the communities. We do this, we can contribute helpfully and truly shifting applied psychological practice to support community resilience. Importantly, encourage the community to create their goals to motivate the whole community move forward together. And the last, conduct a community action plan to achieve those goals. Next, please. This is the techniques that we used last year to engage community to create their own action plan to promote safe, calm, hope, and destigmatization through their actions. We let them write down the idea and options and then put together, read our opinions without any judgment, and discuss together. We decide a group of questions that we use in this process following the roadmap, and they have and as the result they have the action plan. Next, please. These are a draft of the action plans, and each enhancement that we talked earlier has its activity that community is comfortable with. I was surprised that people in the community can pool their efficacy to create many creative activities to help promoting psychological needs to their family and neighbor. After we create this policy and it was adopted to be one of national mental health response, then it was implemented across the country by our mental health professionals from 13 mental health centers, using the strategy of one province, one community to kick off the policy and to create a model of a resilient community to COVID-19. And it turned out very well. My team and I summarize our best practice from 13 mental health centers and publish this book to distribute the wonderful work in the community to people who interest. Next, please. Since its launch in April last year, this national mental health policy has undergone many strategic revisions. We have put the base knowledge of implementation strategy we have to make this policy action happen in the community. Just as we use community-based actions, so we had to design a toolkit to promote community engagement, which is the key points of this policy actions. And the second, we use policy communications and advocacy at all national levels and local level. The third, training of the trainer is still be the important strategy to scaling up, and partnership both government and non-government sector. Also, we integrate our policy into existing systems such as a district health board, who are the group of people who take care of the whole system at the district level. And the sixth, supervision and supportive system still be the basic support system to help local health professionals and community leaders adopt our programs. Next, please. There are examples of community activity in community across Thailand last year, and it shows how people in community use their efficacy and network to respond to COVID-19 and promote their mental health and psychological needs. Next, please. There are two main activities that people use for promoting the sense of safety and create safe environmental and building trust through communications. For creating safe environment, it's quite obvious that only government service cannot offer this to all community at the same time. Many community they use their efficacy to create a safe home and safe community, create community measures such as closing village, setting fewer screening checkpoints to all people who enter and leave their village. They creating the local measure like wearing a mask before go out. This is something that people think is make them feel safe when they live in their community, and they have many community channels to communicate to each other to ensure that everyone in community are informed by trustable news and knowledge. If someone come back from risk areas, everyone or team in the community, they're ready to take care during the home quarantine, and at the same time, they will ensure that all risk cases are in the quarantine properly. The some village they help each other clean up the public areas, and I think this is some of activity that can promote kind of collective efficacy. The moreover, some village they set up a closed mass manufacturing club to produce and distribute clothes masks to the villagers who do not yet have. Importantly, community leader or spiritual leader in the community is considered as important people in communicating and building confidence in community. And many people say they like home visits by our family care team, which includes village leaders, primary healthcare professionals, and some health volunteers, because this team gives them a good care when they cannot go outside and when they need some special needs that they cannot get it. Next, please. This is an example activity that people in community use to promote the sense of calm by their own way. The first, the community leaders, primary healthcare staff, and health village volunteer visit home and give the advice on COVID-19 prevention, symptoms, and self-observations, and mental health care during this crisis. And they use promoting positive coping and psychosocial well-being through effective communication, such as they prioritize mental health care, how to cope with stress via community podcast tower. They reduce anxiety and panic of people about COVID-19 by communicate facts against rumors. And the last, they promote creditability resource for people so they can accurately inform about the current COVID-19 situation. Next, please. This is some of the example activities for promoting the sense of hope. The main idea of this is strengthening community-based psychosocial support for people exposed to the pandemic-related adversity. The family support team will visit they visit vulnerable people and people who need special help and take care of them to meet that special needs, and then create area for peer support in community. Promote sufficient economy, which is a old philosophy that people in rural area they know well, and it have a really positive effect on their life. And then create a system to support people who suffer financial. Some community they create a system that can link people who really need help for government services. Next, please. The last one is about destigmatizations. I think this is all about raising compassion and understand the COVID-19 cases and their family. For example, activity that some village that set a small celebration for people who recover from COVID-19 and are going back to their communities. And later, they use this opportunity to communicate the facts about COVID-19 cases and people who have recovered from the COVID-19. Next, please. I personally think that the community resilience is the point of seeing the true holistic action and self-care taking place in community. Therefore, I personally think that promoting resilience at all levels is not an option to do, but a requirement is a requirement that should be expanded to cover the public use the momentum of the national policy to scale up resilience programs to take care of more people, and strengthen existing program by evaluation to maximize the effectiveness of programs and close the gaps of implementation, improve community mental health preparedness and response, and allow them to adopt their own culture and context to enhance community trust and empowerment. Enhance risk communications, especially among village leaders, will play an important role to build trust in community and ensure appropriate psychosocial service, especially a community-based psychological intervention, which could be available on demand as required and provide to communities. And the last, I think, increase social cohesion in community. A network could be introduced to enhance social cohesion, promote a climate of collaboration during this crisis. And I am delighted to say thank you for inviting me today and thank you for your guys' attention.
Thank you, Ms. Navini, for your presentation. What you present, I think that makes understand what is the concept of what in Thailand have done in many months earlier, and I think that I think about the evaluation of the result of the concept and the process that you have done in Thailand. That will be another question that you may answer for the question after this. I am looking for the question that the participant has sent into the chat box, and I think that the I think that the first question, there's so many questions. The first one would be asked Professor Sir Simon about some detail. There's a question that you have answered already about the mental health problem that you found that there are less mental health problem in the elderly than in the younger population, and I think that this picture is the same in Thailand. We found that the elderly has less mental health problem compared to the younger or in the working group population, and I think that maybe some factor that bring to this picture. We would like to ask you about this opinion about how make difference between the mental health problem in elderly and in the younger population. Why elderly that, as you answered before, that face with the more infected rate, more death rate, but still have better mental health situation?
Yes, I mean, that's certainly a true finding. Now, remember, of course, we're using mental health as a very broad term. And everybody has mental health in the same way that everybody has blood pressure. Whereas mental disorder, of course, only certain numbers of people have, not everybody. And if we look at certain mental disorders, the one we're seeing now quite a lot of is post-traumatic stress disorder in people who've been on intensive care but have survived, but nevertheless spent 2 weeks in fear of their life in the most ghastly, horrible situation. But that's not what we're talking about here. What we're really talking about is mental health. And there the figures show very clearly that the biggest changes have been in the young people, because they're at that period of change in their life, that their educational opportunities have been significantly affected. For a second year running, we have cancelled all exams in schools. Our universities remain closed, with teaching online, which is awful, as I'm sure all of you who've had to do teaching online will agree. And they lose not just education, but everything that goes with education. Growing up, friendships, job opportunities are disappearing, etc. So in that sense, it's not surprising that more of our young people feel lonely, isolated, fearful for their future. And also, I imagine, resentful that for an illness that largely doesn't affect them, their futures have been altered in dramatically serious ways. And so I'm not surprised. But as I said at the start, remember that the young people's mental health in many Western cultures, certainly in America and in the UK, had been deteriorating anyway before the pandemic for other reasons that were not due to the pandemic. And those have obviously not gone away. Now, there are some people, we think around 7 to 8% in the UK, who have actually enjoyed the situations of lockdown. There's a large number of people who have coped reasonably well, but still around a third, 35%, in many studies, who have done pretty badly from their mental health. And the side effects greatly outweigh the benefits. And of course, people like me, I'm now 64, so I'm 1 year away from being elderly. I think I'm still middle-aged for another 12 months. But, you know, I have a job, I have a salary, I have a pension. I live in a fairly comfortable house. When my wife got COVID, which she did, and she was the first doctor in Britain to get COVID, you know, we can work that out, where the house is big enough, we have 2 bathrooms and all that stuff. But for young people, that's much harder. Most of them are living in shared accommodation. Even in this day and age, a lot of our students have very poor Wi-Fi. Many can only share a kitchen table with their siblings and are still sharing bedrooms, without wanting to share a bedroom, I should say. So life is much more difficult for them in lockdown, and we forget that. And then we forget that when we ease lockdown, as we did in the summer, there was a lot of concern that our students were spreading the virus. How were they doing that? By working in pubs and restaurants, serving people like me. So it wasn't that they were misbehaving, being stupid, feckless, we call it. On the contrary, they were trying to earn some money. And also, they compromise most of our hospitality industry, most of the people who work behind bars, in pubs and restaurants. They're not my age, or your age, I'm afraid. They're not our age. And people were becoming very aggressive, talking about students, which is very, very unfair. So I'm not surprised that they're the ones who have suffered most. And it also reminds us that in the end, you know, our goal of, certainly in the UK, of suppressing the virus completely, which is actually not our goal now. We've given up on that. But that would have been at a cost to the economy and our mental health that I think was unsustainable, not in the circumstances that we are. Our job is to learn to live with the virus. There are other countries which are in a better situation than we are, but it's become a fact of life, and we have to decide how do we balance the costs of living with the virus now. And I'm of the opinion, and hopefully some of you will be as well, in our situation, that the cost of mental health of continuing the restrictions as we have for much longer, particularly we now have 1/3 of our population immunized, are too expensive. They are unendurable. And the best thing we can do now is to continue our immunization program to its conclusion and end then the social restrictions that are so bad for mental health.
Thank you so much. I agree with you that the economic effect that that we face bring us more effect, especially in the young group or in the working group. And I have some another question for you in a short question. The participant asks about the basic mental health skill training. I think that you told us about the way that the organization or the the network in the especially in the working age group that may alleviate the mental health problem. Do you have any idea about skill or any training, maybe a basic training that you have done, please?
Yes. What is easy to do is to improve people's knowledge of mental health. So we have been running mental health awareness weeks in the population, training courses by the million. And these have been successful in that people now know more about mental health than they did a generation ago. I'm a little bit skeptical that people didn't know about mental health, but I do agree that they didn't talk about it very much. And as I said, I believe most people have known a lot about mental health, even if they don't talk the language that the people like me and Navni and others do. But all of that has not translated into better outcomes. I don't know of a study in which mental health awareness, or psychoeducation as we call it, giving people knowledge, has improved the mental health of the people they work with. What I have seen is where you give people a skill, not knowledge, but skill, you see more impact. And the study I'm most fond of is not my study. I wish it was, and we're repeating it. It was an Australian study in which doing role play, simple role play, and it was a role play of one situation, which is what to do when somebody in your group, i.e. you are responsible for, starts to cry. And many supervisors find that very difficult. And when you just role played with them how to deal with a crying employee, you got then improvements in the mental health of the employee. So I would always favor teaching people a skill, how to do something. And that's what we have taught our army is, and we're not talking, as I said, 6 years in university. We're talking about a morning, but teaching them a skill, and in particular, not to be frightened by seeing someone crying, because that is whenever they're asked, what they find difficult is someone crying, or also someone saying they're thinking of self-harming, of harming themselves, and people back away. They say, oh, no, I can't do that. Oh, no. If I ask them anything more, they're going to go and kill themselves. Now, we know that's simply not true. But so many people have that belief that just when they could do the most, they do the least. And if I was promoting one thing, it would be teaching people the skill asking, have you thought of harming yourself? And what to do when your employee starts to cry. And that's what people find difficult.
Thank you. It seemed to me that just simple skill that can bring big change to the atmosphere in the company or in the relationship. Thank you so much.
And I'm afraid showing them a PowerPoint about, you see I have a thing about PowerPoint, but showing a PowerPoint increases knowledge, but changes nothing.
Okay, you have to show the way that how to bring us a skill and practice to show what they have to do. Thank you so much. We have another two questions. The one.
Can I just give just add on to what Simon said? I'm Joseph here.
Hi,
Thank
Joseph.
you so much for sharing about the suicide ideation. Yeah, and I sort of mentioned we have a new initiative in Singapore. It's called Caring for Life. Caring for Life. So it's also a new initiative. It's grounds up. It's from the people sector, and basically we're doing mass education, public education of both caregivers and professionals, right? And educational groups. That means the students and all that on how to detect suicide ideation. How to detect suicide ideation, and then basically,
there you go.
Yeah, exactly. So we're actually working on that. So feel free. I think you can actually Google and find out Caring for Life. We've done a few videos, basically building scenarios where people interact in normal circumstances, and then sensing something is not right, and then basically probing some questions, and linking people to lifelines and getting help. Yeah, and
that's brilliant, Joseph.
Support, social support system. Yeah.
Can I urge you, please do a trial? Please do a trial of this.
For researchers, because we are not fully strong in research. So if you email me or what,
you're very strong in research. Come on.
Yeah, for us, we are good at implementing because there's a need.
Yeah, but you're very you are being too modest, Joseph. Of course, you're very strong in research.
Okay,
but please do a trial. Okay, but yeah.
Okay.
Okay, thank you for your sharing. In fact, Dr. Joseph, I am going to ask you about the key success factor that bring your nation more resilience. I think that because your country has faced so many times of outbreak, right? So I think that you have done maybe policy or process that bring your people resilience and can face with this situation. Could you explain about this for a little bit? Thank you.
Yeah, thank you for the question. I think in my slide, basically it's about policy or leadership, and the other part is moving the people. But I think most importantly is really working together hands in hand. That's why I was sharing those stories of resilience, where you have the public sector, which is the government. The private sector, I didn't have time to share some of the videos from private sectors examples, and also the people sector, the 3 Ps, that is the social sector, social service sector, and basically mobilizing people. So in Singapore, we are actually a very small country, a very, very compact country, not like a large country like Thailand or UK. And basically, it's quite easy to get to know each other or get stuck together. So I think one of the things that really helped is started in 2015. The government stance actually changed. We had a nationwide Singapore conversation. What does it mean to be Singapore? What does it mean to be a Singaporean? Right, we had this conversation, and it was led by our Deputy Prime Minister, Minister Heng, who we think will be the next Prime Minister. And basically, he went down to listen to the people, all the various interest groups and all the various stakeholders, whether you're the people on the streets or people that are actually in businesses or in social sectors and all that. So we had a long conversation, And then basically then policies are then informed by the needs of the people needs on the ground. We find out the champions, people who are already doing the work and basically giving them recognition. If you come to Singapore and there's a National Day Award, we have a long list of National Day awardees. Basically, people will contribute to nation building. Basically, sometimes people work for free, but they get an award, acknowledgement. So I think in the Royal Singapore, I mean, this is a website, a YouTube channel that just started a year plus ago. I was looking through it. They're really looking at ordinary Singaporeans, a man on the streets, and then they have a story to tell. So I think it's a continuation of our Singapore conversation, the Singapore story. And what does it mean to be Singaporean, and coming together to see what is the work and defining the work that needs to be done and having a continued conversation and getting the work done together. I hope that sort of explain it a little bit.
Thank you. I think that especially for the contribute of the people that bring you more easy to combat the effect of the pandemic, and the way that you combine both the government sector, the private sector, and the people sector to combat this effect. Thank you. I think that the way that you deal with mental health problem bring us more understanding about what we should do into the near future. I have another question for Thailand. Could you explain more about the meaning of mental health vaccine?
Thank you for your questions, and sorry for unclear presentations about what we mean by mental health vaccine or community mental health vaccines. Actually, we use the metaphor vaccine, or we play with words to make people understand and easy to remember. When physical health have vaccine to protect their health for infections, so mental health have resilient to protect the consequences of the mental health consequence from the pandemic. So that's why we use vaccine as a metaphor for this actions. And for community mental health vaccine is mean the activity that people do to promote for enhancements. If you can remember my slide, safe, hope, calm, and destigmatizations, all activity that people in community do to promote this for domain is we call it as a vaccine. Thank you.
Thank you. I think that the word mental health vaccine show the practice that we usually do in the emergency setting, or the maybe some disaster like psychological first aid. And I think that the to use that you use the name to use the connectedness and the okay. There are so many factors that contribute in the mental health vaccine. I found that there are another question too, and I will read it loud, and I will send this question to the speaker. If you have any answer or opinion about those questions, you may answer into the chat box, and the participant may read it in the website. The question may be about the community mental health, especially in some situation or some area like a big city or in a compact community. We usually found that it is harder to do some intervention or any mental health project, especially in the big city or in the compact community compared to the remote area. And there are so many mental health problems in the city before the pandemic too. So I think that for answering this question, maybe by your opinion of the speaker, I think that this is final time to for the conference. And in the last period of the conference, I would like to be a representative of the meeting and on behalf of the mental health of Thailand, and I would like to thank our speaker that contribute your time with us during this conference. Professor Sir Simon Wesley, Dr. Joseph Leong, and Ms. Navini Krehong, and Dr. Thasak Detkong. Thank you to you all. See you again.
Thank you very much.
Thank you very much.
Yeah, thank you very much. It's been a pleasure. It's now 9 a.m. in London. I'm afraid I now have to go to work.
Okay. What time is it in London?
9 o'clock.
9 o'clock.
So I'm about to teach medical students in 15 seconds. So I now have to depart.
Okay, thank you so much.
Okay, thank you very much.
Okay,
good luck.
For
good
the
luck.
participants in the conference, I think that we have a little bit time to evaluate the session. Let Dr. Sankamon please.
Thank you very much for the moderator, Dr. Thasak Detkong. Everyone, please turn on the camera to take the photo together right now. Please. Okay. Please turn on the camera. Wow, there are many participants or very good. Okay. 1, 2, 3, cheese. Hi. Okay. Okay. Okay.
Thank you.
Everyone, before you leave the meeting, please evaluate this conference by QR code. Your comments are important information for developing the next activities. Thank you so much. We hope to see you all next time for a good activity together again. Thank you very much.